uh, bahasa Bali. Om Swastiastu. Selamat pagi, Rahajeng Semang is called. Good morning in Balinese is Rahajeng Semang, Prof. Frederick. In this morning, I will be very glad to accept you all, our distinguished guests from Baxter and from Chris Lincoln Rollingen Academic Hospital, University of Tübingen, Germany. This morning, I will be glad to have a meeting with you all, our distinguished guests, and our college here, and distinguished and fellow scholar from in the field of anesthesiology. So it's my very great privilege to welcome you, Prof, and all your team today in our roundtable discussion about Supran, of course, Desflurane. The discussion may be about the platform will be dedicated in advancing knowledge and pressing challenge in our field in anesthesiology, in OR, of course, maybe in neuroanesthesia. As we gather here, all of us, we bring together a wealth of your expertise to share with us in Bali, the first of the perspective, the share of commitment to improve patient care in our hospital, in Ngurah Hospital, in our evidence-based practice in anesthesiology, of course. Today the agenda is the promise to engage the conversation, Prof, about your expertise, and if any of our resident or fellow here have any further question to have an based knowledge or based on your expertise to do with any of OR in anesthesiology and the treatment with OR in Desflurane, of course. I declare this roundtable, Prof. Prof. Frederick. The discussion is now officially open, and thank you. And let begin in this short time to your very broad of your expertise to share with us, and we are glad to learning with you, Prof. And we discover a lot of the knowledge of Desflurane to our study program here in Bali. Thank you. The time is yours, Prof. And now you still young man.
I'm not, but thanks a lot for. I think everyone can hear me.
Yes, of course.
Yeah.
Yeah.
Okay. So it's all about patient safety. Yeah. Patient care. This is why I'm happy to be here. And I'm based in the southwest Germany. This is all Germany here. It's Berlin and Hamburg and Munich. And I'm based in. What? Okay, there are people online, but this is not working. Okay, so I'm based in southwest of Germany, close to Stuttgart. And you all know Stuttgart from its famous brands like Mercedes, like Porsche, like Hugo Boss Fashion, like Bosch Electronics. So this is all where we live, and Reutlingen at the University of Tübingen is around 30 kilometers south of Stuttgart, so very close. And if you're visiting me at my hospital, just around the corner is the Boss Fashion Factory. So you are welcome to whoops, this is the wrong direction. Well, it's an academic hospital of the University of Tübingen, and we are doing about 15,000 anesthesias every year. All disciplines except done in specific centers. In Germany, Anesthetists are not only doing anesthesia, we are doing intensive care as well, as you can see. And we also do pre-hospital emergency. So when you call that there's an accident or an ambulance is going there with 2 paramedics, and the emergency doctor car is going there as well with 1 paramedic and an anesthesiologist on board. And they are having all the equipment like ventilators, like satellite transmitting ECG. So pre-hospital service as well. Yeah, because we are the ones who are able to prevent life, to stabilize in critical situations. And we are doing pain and palliative care. Out the center of excellence for Baxter in terms of modern anesthesia concepts, and for Karl Storz in terms of airway management concepts. Having a lot of international guests every year to visit us, to be trained in these kind of topics, and probably one or another knows those Indonesian guys. This is Dr. Anas from Jakarta. Yeah. Yeah, and so this is already a couple of years old. It's not the newest picture, but I think this was when they visited me in terms of airway management. So if anyone is interested, welcome to department. Well, what will I talk about? I mean, I will talk about our clinical needs on a daily basis. I will talk about the pharmacology of Desflurane, how to use it in a safe way. I will talk about patient safety aspects, because this is the most important thing. We are not paid as anesthetists to have an easy job. We are paid to provide patient safety. This is the utmost importance. Just always remember, as a patient, what would I like to have? Would I like to have the easiest way of getting anesthesia, or would I like to have the safest way of anesthesia? And this is what you always have to keep in mind. Would I do it for my father, my mom, my grandmom the same way? Or do I do it because it's just convenient? I will talk about the philosophy of metabolic flow, and I will talk about the discussion about an environmental impact of anesthesia. And there is a lot of rumor about the last topic within the last few years. But very recent data from climate scientists give us a very clear answer on this topic. Yeah? It's a pretty old data from 1991, so around that time when I visited Bali first time. But they are still very valuable and very important. And please keep those data in mind, even though they are from 1991. Because par et al. Were looking at subsequent respiratory complications in accordance to the status of awakeness at the end of anesthesia in 3 different age groups. So green, 70 years or older, 50 to 70, the orange bars, and pink, the younger one, 30 to 50 years of age. And you see, group 1, people were fully awake at the end of anesthesia. The incidence of postoperative pulmonary complications was very, very low, below 1%, no matter which age group. But as people were less awake at the end of anesthesia, like being group 2, being responsive only to verbal command, already in the elderly but in the mid-ages, there was a dramatic increase in subsequent respiratory complications. Group 3, responsive only to physical stimulation. They had to be shaken to wake up. And you see even the mid-agers are dramatically increasing with subsequent pulmonary complications. And when people were unresponsive, again, even the younger ones, yeah, had a dramatical increase. So when sometimes people tell me, oh, you know, I like it as an anesthetist when my patients are waking up so gently. Yeah. Just driven out asleep of the OR, get rid of them, go to the PACU. Yeah? The risk of pulmonary complication is huge, up to 10%. So patients have to be awake and not gently waking up somewhere else. It must be in the OR. This is why I want my patients to move themselves from the operation table to the trolley, yeah, to get out of this is the quality measurement for me, yeah. What are the challenges? Well, you all know, we cannot change the preconditions. People are getting older and older, people are getting more obese, people are having more and more comorbidities. We cannot change this, we have to deal with it. But the rest, like looking that there is no residual neuromuscular block. I mean, just the recent guidelines from the American Society, from the European Society, published last year, is that every patient receiving a muscle relaxant should get neuromuscular monitoring, quantitatively, TOF measurement. Everyone getting a neuromuscular block. Because we know the variability in return of recovery is dramatic. About 40% incidence of residual paralysis. I mean, 4 out of 10, that's a huge number. Would you fly on an airline where 4 out of 10 flights are falling down? No. But in anesthesia, we just accept it. In my department, every patient receiving a neuromuscular blocker gets neuromuscular monitoring, and they have to sign or to draw into the anesthesia record the final TOF value. And if this is not 90% or more, they have to reverse the patient. We need a final TOF ratio of above 90 before the patient is extubated. Before the patient is extubated. Would you like to wake up with residual paralysis, being awake and not being able to move or breathe properly? I will talk about the residual effects of volatile anesthetics and of propofol as well. Yeah? There are residual effects which we have to consider, and those are not minimal. I will show you. And of course we know about the effects of opioids. Yeah? So altogether, if we fail, it might lead in respiratory arrest or most respiratory complications. And the cost of a pneumonia in Germany is around 30,000 euros per patient. 30,000 euros. Because prolonged stay in the hospital, the treatment costs, the diagnostic costs, not talking about the personal harm of a patient receiving that respiratory complication. So it's very important to avoid it. This is our duty as anesthetists, and you are the future of our discipline. So it's so important that you are working thoroughly on all these kind of things. Well, when we are looking about the optimal drugs, we want predictable and reliable drugs, yeah, with a consistent duration of action, with fast recovery, with a fast return of airway reflexes, no impairment of ventilation, and no impairment in cognitive function. Since our patients are getting older and older, the danger of delirium postoperatively is pretty high. And a fast recovery is something that prevents it. The same like not using benzodiazepines for these kind of patients. Yeah? In my operation room, there is no midazolam, yeah? Because it's a dirty drug in terms of cognitive recovery. Yeah? So we don't use midazolam at all in the OR for our patients, because we want to avoid cognitive dysfunction postoperatively. Well, let's come to the chemistry of Desflurane. Well, the molecule of Desflurane is pretty similar to the molecule of isoflurane. Yeah? There is one tiny little change. And this is the chlorine atom of the isoflurane is replaced by a fluorine atom of the in the Desflurane molecule. And this tiny little change makes changes from a high soluble, slow molecule into a low soluble super sports car made in Stuttgart, just around the corner of my hospital. Yeah? Why do I show you this? Not because this is made in Stuttgart and this is made in East Germany in the 80s. Yeah? No, the thing is from slow to fast. And if you are using Desflurane the same way you are using isoflurane, you will cause trouble. This means like if you're pressing the gas pedal here like you are used to this old Trabi, which has an acceleration like tuk, 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 tuk. Yeah? When you press the gas pedal fully, when you press the gas pedal here fully, it's like vroom. So when you cause an accident outside in the street of Denpasar, yeah, in the traffic jam, is it a problem of the car or is it a problem of the driver? Yes, it's a problem of the driver. And this is why I will show you how to drive the sports car in a safe way. Yeah. Well, the low solubility causes that you have a fast wash-in. Within 2 minutes, you have 80% uptake in the patient. Yeah? You have a higher concentration, but you have fast uptake. Biggest advantage of a low soluble drug is that no matter how long you are using, you always get rid of the drug very, very fast and very, very consistently. This is the big advantage of Desflurane. No matter how long you're using it, patients are always waking up very, very fast and reliably. Yeah? These are the partition coefficients, and as you can see, the lower the number is, the faster the drug is eliminated from one compartment to the other. And you see that it's always much, much faster than sevoflurane or isoflurane. Yeah? This is really the fastest volatile anesthetic we are currently having. And another thing which is important, look at the metabolic rate. The metabolism, there is no metabolism for Desflurane. 0.02%. Yeah? Whereas it's like 10 to 20% for halothane, it's around 8% for sevoflurane. This is important when we come back to the topic of metabolic flow, which I will show you later. Yeah? If you do not have any breakdown products, you can reuse the exhaled gas again and again and again. And that's what we call metabolic flow, because this saves also money, and this comes very important in terms of economics. Well, as I said, low solubility, you need a higher concentration. The mark for Desflurane is 6%. For Sevo, it's around 2%. For isoflurane, it's around 1%. Mark is age-related. In pediatrics, we need a little bit of higher mark, around 9, around 6 for pediatrics, and around 5 for the elderly. In the presence of opioids, like 3 mg per kilogram, the mark is going down from 6 to around 3.2. Nevertheless, we all know MAC means half of the patients are still reacting to a surgical stimulus. This is why we have to add another 50% of that to be on a safe level in terms of anesthetic depth. That means 3.2 plus 1.6, which is 50% of that number, is 4.8. So we consider in my department the end-tidal concentration in Desflurane anesthesia should be 5 or a little bit above. Okay? How to use Desflurane in a safe way? How to drive the sports car safely through the traffic jam of Denpasar? Well, very easy. This is the rule, we call it the rule of 24. What does it mean? We start the vapor at 12%. First of all, we induce the patient with fentanyl, propofol, probably put a relaxant in, put the airway in, a tube, or no relaxant and an LMA. And once the airway is set, we start with the wash-in. In my department, there is no ventilation with a volatile gas before intubation or before LMA is set. Yeah? 2 reasons. With Desflurane, it's not necessary. And secondly, and this is the more important reason for me, I want to protect all the young people and even the old ones in the operation room. Because we do not know what the subclinical doses of all those volatile anesthetics are doing in our bodies when we are spreading them around, when we do ventilation on the mask. And there is no need to do this with Desflurane. Therefore, if you walk into my OR, you will never smell any anesthetic gas. There is no anesthetic gas. It's in the patient, and it's in the suction system after the patient. But there is no smell of anything. Yeah? This is what I really experienced when I was traveling the last week through Asia. In a lot of ORs, when I walk in, oh my God, it's smelling. Yeah? After Sevo or any other gas. Because for 10, 20 years, always those doses of volatiles due to mask ventilation. There is no need with Desflurane. And that's what you have to consider. Not only about what is best for the patient, also what is best for us, yeah, in terms of health. There's a lot of nurses, a lot of young doctors, and like us, the old guys, yeah, I mean, what happens to that subclinical doses we are inhaling every day? This is not necessary. Okay, so I start, after the airway is set, I connect, and I start. What does it mean? I put the vapor at 12, and I put in 2 liters fresh gas flow, 1 liter oxygen, 1 liter air. Okay? Well, one might say now, well, he just said he wants an end-tidal concentration of 5, but he puts the vapor at 12. We have to consider that the capacity of the circle system inside the anesthesia machine, no matter it's from Draeger, from GE, from Mindry, or whatever anesthesia machine you are taking, is around 6 liter. Okay? So when I wash in the beginning with 2 liters fresh gas flow, I'm replacing in the first minute only 1/3 of the anesthesia machine. And 1/3 of 12 is 4. Okay? In the second minute, I'm applying another 1/3 of the machine. That means 4 plus 4 would be 8. But during those 2 minutes, the patient is already ventilated, and therefore there is 8, because we will have around 5 or 6 after 2 minutes. And that's what we do. And if you are doing like 8 and 3, it's the same, because with 3 liters fresh gas flow and 8 on the vapor, 3 times 8 is also 24. You replace half of the anesthesia machine, and half of 8 is 4. Same, almost same, but yeah, okay, similar result, different approach, but same. Okay, so never ever exceed the rule of 24, because we all know Desflurane can cause tachycardia, Desflurane can cause laryngospasm and bronchospasm. Well, sports car can cause accidents, but is it a problem of the car or is it a problem of the driver? Okay, so within this technique, yeah, it takes you around minutes to get to an end-tidal concentration of 5 to 6. And this is adequate depth of anesthesia. And this is what we want to achieve. This is what it takes 2 minutes, 2 to 3 minutes to be there. And once we get to that point, and this is what I would like to show you. You see, this is the wash-in, yeah, and then you see this peak, and this is the point when I dial down the flow to 200 milliliters of oxygen only. Yeah, and you always see this kind of kink. Yeah, this is why when I wash in, I do not stop the wash in at 5.0, I stop the wash in at 5.6, 5.7. Because when I go down with the flow, then you will always see a little bit of drop in the concentration. Yeah, and if you stop at 5.0 in the wash-in phase, it will drop down to like 4.5. Yeah, but I want to be a little bit above 5. Yeah. Okay, and this is what we do in my department. We are going down to metabolic flow, 200 milliliters of pure oxygen only. This is what we do, metabolic flow, because a patient is taking out of the anesthesia machine only oxygen. And of course, when I started anesthesia, we had high flows like 2 liters, 3 liters, even more than that. But this is the technology of the last millennium. Yeah, and I guess every one of you is having a modern mobile phone. Yeah, but in terms of anesthesia technique, people are still using techniques from the last millennium, having high flows like 2 liter fresh gas flow through anesthesia. This is not a modern technique. Yeah, you're not riding a horse anymore or a bicycle when you come to the hospital. you are using more modern equipment. And I think you should use modern techniques for your patients as well. Well, if you go down to 200, the vapor has to be at 12. If you go down to 500 flow during anesthesia, the vapor should be at 8. What are your usual flows here during anesthesia? Fresh gas flow? You have a lot of money here in Bali. And I will show you a little bit later. You are throwing money out of the window. Sending money to America. Germany is... Yeah? We have to reduce the flow. But because I guess every one of you is closing down the shower when you are leaving home in the morning. Because keeping the shower running is costly. And the more flow you have, the more it costs. But it's his cost because he's head of department. Yeah. Yeah. But I do not want to spend money, too much money to Baxter in America. I want to keep it in Germany. And this is why you should reduce the flow. And I will show you later in the OR how we do this. Yeah? Okay? So keep in mind, Desflurane, it has a solubility, it has a fast onset and offset, and there is no metabolism. Well, let's talk about the clinical data. This is morbidly obese patients, yeah? And you see between Sevo and Desflurane there is a difference of 4.5 minutes in eye opening, yeah? But when we look at more quality related data, you see stating the difference is already 7 minutes. And when we look at stating date of birth, the difference is already 10 minutes. And this is due to the low solubility. When you have a low soluble drug, it dissipates very, very fast, and the recovery of cognitive function, of quality of recovery, so the differences are always bigger. It's also very consistent when we are looking in comparison to Tiva, because Tiva we all know is sometimes working very well in the wake up of patients, but we all know that in some cases it is not. The predictability of a low soluble drug like Desflurane is much better than any other technique, especially also when we compare it with Tiva. You see the wake-up criteria is around 8 minutes different. Yeah? Initially there is a 6-minute difference, but again, of recovery. And what shows best is the standard deviation. You see for Desflurane, this is in elderly patients, you see 3, 4 minutes time difference. Standard deviation, yeah? For Tiva, it's 6, 7, 8, 10 minutes. And this is the fast and consistent recovery. But timing, predictability is not about only timing. It's also about patient safety. And I will show you some very interesting data in terms of patient safety. This is a study done on the return of airway reflexes after Safey and Desflurane in young and volunteers. They underwent laparoscopic cholecystectomy. They were allowed to recover spontaneously. And once they were proper responding to commands to show the tongue, to press the hand, lift the head, the foot. They were asked to drink 20 ml of water. Yeah, so A2 patients, not old people like me. Yeah, so, and they were asked to drink 20 ml of water. And what happened? They found that in the Desflurane group, every patient 2 minutes after proper responding to command was able to swallow properly. Look, gone. But in the Sevo group, less than 20% of the patients were able to swallow properly. Some were drowning, and some were coughing and aspirating, because there was still a pharyngeal dysfunction occurring. Yeah? And the same group did a couple of years later the same setup, looking at the effect of increased body mass and anesthetic duration on the return of airway reflexes. And what did they find then? Well, This is a different graph, but look at the distribution of the black dots. This is the return of airway reflexes after sevoflurane, and look at the distribution of the white triangles. This is the return of airway reflexes after Desflurane. And you can see, even in a body mass index of 20, which is a body mass index I can just dream of, yeah, there is a huge variability in the return of airway reflexes after sevo, but not with Desflurane. In my group, you know, like 30, still very narrow, whereas it is huge for sevoflurane. Yeah, and if we convert this table into the table from the first study, you can see if you have a BMI of above 30, still 96% are able to swallow properly after extubation. Yeah, 2 minutes after proper responding to commands, they were able to swallow properly and protect their airway. If you have a BMI of above 30, less than 20% of the patients are able to swallow properly. And it takes to more than half an hour until they are saving their airway again. I mean, we all know in the early postoperative, especially after laparoscopic surgery, that the incidence and the danger of regurgitation is very high. And so it's very adventurous if we are able to protect our airway from aspiration. So this is outcome relevant. And if you ask me as a patient what I would like to have, it's very clear that I want to have Desflurane, because I want to recover fast, I want to recover predictably, and I want to save my airway as good as possible. And they were also looking at the incidence of anesthetic duration on the recovery of airway reflexes. And you know, sometimes people tell me, oh, you know, it's just a short operation, just very short, less than an hour. There is no difference between Desflurane and sevoflurane. But as you can see, the black dots are the return of airway reflexes in the sevo group in below 1 hour anesthetic duration. And there is still a huge variability. And it's very clear, because as I've shown you in one of the first slides, the uptake of sevo takes up until 15 minutes to have an 80% saturation in our body. And after 15 minutes, so the patient is almost saturated. But with the high solubility of sevo, the delayed elimination starts. And with Desflurane, there is no delayed elimination because it has a low solubility. And this is the big advantage, that you get rid of the drug no matter how long you anesthetize a patient, yeah, or what the body mass index is. This is a neurosurgical study. You do neurosurgery here? Yes. Ah, okay, very good. Well, this is a nice study on early postoperative recovery, cognitive recovery, and gas exchange patterns after balanced anesthesia with sevo and Desflurane patients. And what you can see here is interesting, that 15 minutes, 30 minutes, and 45 minutes after extubation, the pH value in sevo patients are statistically going down. And this is associated with an increase of CO2. So there was a ventilatory impact in sevo patients compared to Desflurane patients. Again, the pharyngeal structures are a little bit collapsing, and therefore they had an increase in the CO2 level and an associated drop in the pH values. You all know that CO2 should remain stable because it alters cerebral blood flow in those patients, and this is very critical to avoid. Secondly, they were looking at the recovery data, and this was 19 minutes in the Desflurane group compared to 39 minutes in the sevo group. And of course you might say, well, 20 minutes, does it matter? Yes, it does, because after neurosurgical craniotomy, neurosurgeons want to investigate if they can move everything, if they feel everything, to detect recurrent bleeding. And if you realize recurrent bleeding 20 minutes earlier, this might have a big impact in the outcome for the patient for the rest of his life. Yeah? When we look at the recovery of cognitive function, again, there is only a minor drop in the Desflurane group compared to a huge drop in the sevoflurane group. Again, this is associated with the higher solubility of Desflurane. This is a very interesting study from Martin Soremba in Germany about a comparison of Desflurane versus Tiva and the effects on early postoperative lung function in overweight patients. So actually, when he called me and said, I have a project, would you like to participate? I would like to investigate the effect of anesthesia technique on lung function. I was thinking, you really think there is a difference? I mean, how can anesthesia technique influence lung function? Yeah. Unfortunately, I did not participate in this study. This is why you can't find my name there, because I said, I don't think there is a difference. Yeah, I did not participate. I was wrong. I was proved to be wrong. Yeah. Fortunately, the thing is, they were looking at the saturation values, SpO2 levels, comparing to the baseline, yeah, preoperatively. Yeah, and you see that in the black bars are Tiva and the light bars are Desflurane. And you see directly after surgery, half an hour after surgery, 24 hours after surgery, 2 hours after surgery, and even 24 hours after surgery, the drop in the Tiva group was significantly greater compared to the drop in the Desflurane group. So the question is why? And what is that they did lung functional testings, you know, directly after surgery, half an hour after surgery, 2 hours after surgery, and 24 hours after surgery. So those patients, they were awake because they had to do the lung functional testings. They were doing functional vital capacity, and they were doing the FEV1 and the flow measurements, MAF 75, MAF 50, MAF 21. Yeah? And you see at any time point, any testing, there was a highly significant difference towards Desflurane. So Desflurane patients had a highly significant better lung functional testing results compared to Tiva. So the question is why? They were all awake. They were all doing their best. But the difference was highly statistically significant. And what's the reason? Well, the reason has been shown already a couple of years earlier, published by Peter Eastwood in the Anesthesiology. And Peter Eastwood showed that there is a collapsibility of the upper airway at different concentrations of propofol. Yeah? And he clearly showed at various concentrations of propofol that the maximum inspiratory flow is just going down. There is a collapsibility of the upper airway. He could reduce this effect by increasing PEEP. And I always compare it, what probably some female experience, when men are drinking alcohol, they snore at night. So alcohol, like propofol, does a collapsibility. It weakens our pharyngeal structures, even though when we are awake. And this is why those Tiva patients in Martin Zaremba's study had less good lung functional tests, because even at the status of awakeness, they were awake because they had to blow. There was a collapsibility of the upper airway, so there was an obstruction up here. And this is why the lung functional testing was worse. And this is why saturation values were less, because there is a certain inhibition of ventilation in those patients, whereas there is no inhibition in Desflurane patients. Why? Because of the fast elimination due to the low solubility, the structures gain their natural strength again to keep the airway open. Well, let's come back to the technique of metabolic flow. I said we are using 200 milliliters of fresh gas flow only in my department. Yeah? And low flow or metabolic flow anesthesia is nothing else than reusing the patient's gas after CO2 absorption. I mean, if you have a swimming pool in your garden here in Bali, would you replace the water, half of the water every week? No. You would fill it once a year, and then you try to keep it clean by putting in chlorine, because all the rest would be a waste of money. But why are you using 1 or 2 liter fresh gas flow every minute to replace 1/3 of your anesthesia machine every minute? Why do you do this? Because you've always done it like that? That's not necessary. What is a patient taking out? Well, a patient is taking out only oxygen. What are we taking out here every minute? We are taking oxygen out. And what is the amount of oxygen we are taking out? It's the oxygen consumption during anesthesia under normal physiological circumstances is around 2 to 3 milliliters per kilo. So a 50-kilo woman, 150 oxygen. A normal gentleman like you, 70 kilo, 210 milliliter. A 100-kilo person like me, 300 milliliter of oxygen. That's all we metabolize, metabolic flow. That's all we need for living. Yeah? And if you have a swimming pool here, you would probably look on a weekend how much water the sun evaporated over the last week. Probably at this week it would overflow because of the heavy rain we had. Yeah? But usually the sun evaporates and this is what you replace. And I replace to the anesthesia machine every minute what the patient takes out. Only 200 milliliter of oxygen. Yeah? And this is the calculation. 3 milliliters per kilo per minute. This is the oxygen consumption under normal physiological conditions. Yeah? I mean, of course, a septic patient takes more, but we do not have septic patients every day in the operation room. And this is what we can see, that usually we have a flat line. Sometimes there might be a decline in the concentration of the machine, and this is when we have to go up with the flow, of course. But if you have a lady with 50 kilos, you know, you will see there is an increase in the content of the machine. And this is what we have to observe. When we are on metabolic flow, we have to observe the oxygen concentration, the inspiratory oxygen concentration to the patient. Yeah? This is what I have to keep in eye, but I will show you later in the OR. And this is this is a recording from one of my patients. You see, this is 100%. The yellow line is the oxygen content in the anesthesia machine. This is pre-oxygenation with 100% oxygen. Then we intubate here, and this is when we start wash in Desflurane. This is the Desflurane concentration. You see, we start with 12% and 2 liters fresh gas flow. Yeah, 1 liter oxygen, 1 liter air. And you see over time the oxygen content is going down to 60% because 1 liter oxygen, 1 liter air in the wash-in phase is around 60% mixture. And during that time, there is the increase of the Desflurane concentration for the patient. And this is the time point when we reduce to metabolic flow, 200 milliliters only. This is the concentration of Desflurane. And this is the oxygen concentration inside the machine. So the consumption of the patient meets exactly the delivery. Yeah? If you have a higher consumption, it would go down like this, but this is the ideal situation which I can show you. This is when the consumption is higher. You see there is a steady decline, but there is still around 60% oxygen in the machine, so you don't have to worry. So even a patient like me, I would start with 200 milliliter of oxygen as well. Why do I do this? Because less fresh gas flow is less consumption of volatile anesthetics. Well, if you have 2 liters fresh gas flow, the hourly consumption of Desflurane is 42 milliliters. Yeah, the vapor gives 42 milliliters of Desflurane to the machine every hour. If you have a flow of 1 liter, the hourly consumption is only 21 milliliter. At half a liter fresh gas flow, the hourly consumption is 10 milliliters. And in my department, with 200 milliliters fresh gas flow, the hourly consumption is only 4 milliliter. What does it mean? I mean, to really bring it to the point, this means that with 2 liter fresh gas flow and an hourly consumption of 42 milliliter, a bottle which is delivered with 240 milliliters. This is what Baxter delivers. The bottle is containing 240 milliliters. So this bottle is gone within 6 hours. Within 6 anesthetic hours, it's gone. Like one Whipple's operation, and you call the nurse and say, refill. But when you reduce the flow to 1 liter, the same bottle lasts already for 12 anesthetic hours. No difference in quality of anesthesia. Same end-tidal concentration, same quality of care. Double the time. But at half a liter fresh gas flow, the same bottle lasts already for 24 anesthetic hours. And in my department, the same bottle lasts for 60 anesthetic hours. Same quality of care, same concentration for the patient. But I'm replacing only what the patient takes out. And I do not blow it into the sky because I have the high flow. Yeah? Because I'm replacing half of the water of my swimming pool every minute. And in terms of costs, you know, if you have 2 liter fresh gas flow and the bottle is gone after 6 hours, the hourly cost of the anesthesia is 20 euros. Baxter will love you when you are using 2 liters fresh gas flow. Yeah? But you know, if you have 1 liter fresh gas flow, the hourly cost is 10 euros. At half a liter fresh gas flow, the hourly cost is 5 euros. And Germany is a poor country. We cannot afford that cost. This is why our hourly costs are only 2 euros. The lower the flow, the less money you pay. Well, you're not responsible for the costs of anesthesia, but he is. Yeah? And again, even though a huge difference in the price, there is no difference in the quality of care. They all have the same level of anesthesia. It's just that you do not waste Desflurane. Don't blow it out through the chimney. Don't send the money to America. Keep it in Bali. Yeah? And how did I get to that? Well, I'm head of department now for 25 years. So I'm really an old man, an old chairman. In 2008, my pharmacist called me and said, Professor Püringer, I just got a wonderful offer. What is the bottle of Sevoflurane 30% cheaper than Baxter does for Desflurane? And he was looking at my consumption list from the last year, from 2007, and he found out that I spent, this was the most used and therefore cost-intensive drug I was using that year. This was 67,000 euros. And as a pharmacist, he was just thinking, 67,000 euros, 30% is 20,000 euros. Wow, that's a big saving. So he called me, we should change to Sevo. And I said, let me have a look into my electronic system. So I was looking about the amount of anesthesias we've done with Desflurane and with Sevo. The Sevo costs were only 4,500, so about 5% of the Desflurane costs. But we have done 8,204 anesthesias with Desflurane, and we have done only 278 on Sevo. And when you divide the amount, the total amount of money divided by the anesthetics, you will see that the average cost of an Desflurane anesthesia was 8 euros compared to 16 euros with Sevo. He never called me again. And I'm still using Desflurane. Well, it's very clear. It's not the price of the bottle, it's the flow. And because Sevo has a breakdown product called compound A, which is nephrotoxic, we cannot use it in a circle system. We have to have higher flows. And I just showed you very clearly, if you have higher flows, you spend more money. So when you reduce the flow, you save money. And we are using 5 times higher flows for Sevo because in Europe, we are not allowed to go below 1 liter fresh gas flow with Sevoflurane. But there is no restriction for Desflurane. This is why we go down to metabolic flow. It's the flow that is important. Always keep in mind, the higher your flow is, the more money he has to spend. Yeah? Well, let's talk about environmental impact. Yeah, I mean, this is a big discussion, you know, and everybody is afraid of global warming and the greenhouse effect. You know, this is here in the troposphere, that there is a lot of molecules that are inhibiting the reflection of the radiation back into space. Yeah. So first of all, we have to look which molecules are killing the ozone layer, and so there's no impact of desflurane and sevoflurane on the ozone layer. There is an impact of nitrous oxide, halothane, and isoflurane. But more importantly, what is causing the greenhouse effect? Well, first of all, water, and then there is carbon dioxide, which is about a quarter of the whole effect. Yeah, but if we exclude water, which we need for living, about 60% of man-made greenhouse effect is caused by CO2. About 70%. Yeah, this is what we should keep in mind. And about 1/3 is all the other gases, like methane, like nitrous oxide, like sulfur fluoride. Have to have a look at. And so this is the International Space Station, and they just added recently an emittoscope. So this emittoscope is flying with the space station around the Earth to look where in the world with a lot of emissions that are causing greenhouse effect. Yeah. So probably one might have thought they find Professor Püringer's hospital because he's using desflurane heavily. Yeah. But what did they find? They did not find my hospital. They found the gas fields of Tajikistan. So Tajikistan is one of the biggest gas producers in the world, beside Qatar. Yeah, Qatar is number 1, Tajikistan is number 2. So when they get the propane, they only collect the propane, which has the high burning capacity. This is what you get in the red bottles when you buy gas. Yeah, and they do not collect methane, because methane has a low burning capacity, so they just let it go into the atmosphere. So the question is, how much is, yeah? And when we look here, they are emitting about, in Tajikistan, 1,680 tons of methane per hour. This emittoscope on the space station was identifying some coal-burning factories in China who produce energy. They are emitting 2,460 tons of CO2 every hour. And in contrast, the annually per year production of desflurane is less than 1,000 tons. Okay? So this is what in Tajikistan and China is emitted within 1 hour. Yeah? And if we put it into relation, and this is why I show you this, the emission of desflurane, 10 years, lifetime in the atmosphere, only 10 years, emission 960 tons. Sulfur hexafluoride, nobody's talking about this. This is the gas field in tennis balls. Yeah, you see, 25 times more annual production, and the lifetime in the atmosphere, 3,200 years. Yeah. Look at nitrous oxide. It has a lifetime in the atmosphere of 125 years, and the annual emission is 125 million tons. Methane, 75 years in the atmosphere, 340 million tons. Yeah? CO2, 100 years, lifetime in the atmosphere, 100 years, ladies and gentlemen, and the annual production, 38 billion tons. Yeah? So there is a little bit of nothing which has a high importance in terms of quality of. And if we convert this again into a relation which is a picture for you, 38 billion tons is the size of the Empire State Building. Okay? This is the CO2 emission annually, every year. What is in relation? The height of the desflurane emission. And the height of the desflurane emission is 0.03 millimeters. Okay? So when people are discussing we should avoid desflurane, we are avoiding 0.03 millimeters. How big is this? Can anyone show me? Yeah? Okay. So we can work on 443 meters. Yeah? This is what we have to do. But I'd like to introduce you to Professor Dame Julia Slingo. She's probably the most renowned and most awarded climate researcher in the world, and a couple of interesting publications. Yeah? And just to show you who she is, she was a member of the European Center for Meteorology. She was a member of the National Center for Atmospheric Research in the US. She was the chair of the National Center for Atmospheric Science in Reading in the UK. She was the founder of the Walker Institute for Climate Research. She was the chair of the Met Office, which is an institute containing of 500 researchers working on climate change and weather prediction. Yeah? She has been knighted by Queen Elizabeth. So she's really one of the great scientists in terms of climate research. Yeah? And she just recently gave a lecture in Scotland about the impact of Desflurane on climate, and she said, anesthetic gases have a vanishing small effect on the radiative forcing and Earth's energy budget, regardless to their high global warming potential. Lifetimes are too short and concentrations are too low. Their contribution to radiative forcing will be lost in the complexity and noise of the climate system. They have no climate impact because the amount is too low compared to CO2, compared to methane, to nitrous oxide, where they are millions and billions of tons emitted, less than 1,000 tons for Desflurane. They have no climate impact. And these are the recent publications. This is from January last year in Anesthesia. This is another publication from Anesthesia Analgesia August last year about the impact of climate change. And this is a very new paper by Professor Kleinberg from the US, and he just published this last month in Anesthesia Analgesia, and he said that about Desflurane, he calculated the effect when the whole world is doing for 100 years only Desflurane anesthesia. So no TIVA, no SIVO, nothing else. 100 years only worldwide Desflurane anesthesia. 100 years, yeah, because calculated lower, he didn't find anything. Within 100 years, he found that for the first 30 years, there is an increase in temperature by 0.002 degrees. And after 30 years, there is a saturation in the atmosphere, and then it would be stable, or it starts declining again. So there is no impact, because CO2 is the danger for us, yeah? And if we do not reduce CO2, we will not save our planet. And again, no contribution to global warming, because it is like for the next 100 years would be responsible for an additional warming of 0.00015 yeah, degrees, okay? And just for all of those who are thinking, well, we should move over to TIVA and to propofol because propofol is such a nice drug. Well, propofol is a nice drug. I love propofol for induction of anesthesia. But we have to be aware. And I would just like to show you some data about propofol, which you probably did not know so far, but they are just important to know. And what I would like to say is just the world is not black and white. There is not the good thing and the bad thing. The world is colorful. We have to realize on a scale from 0 to 10 about toxicity of drug, propofol is on level 9. Yeah? We have to understand that about up to 50% are thrown away unused. Where do they put it? Into the sink? Well, probably. But you have to know, there is no biodegradation in water. It has a high potential in bioaccumulation, and it's a problematic waste disposal. Actually, it should be burned with temperature above 1,000 degrees. What is burning? That's causing CO2. Okay? Again, if you put it in the sink, it's nice, it's gone. But you know, it accumulates in soil. It's aquatoxic. If you put 1 drop of propofol into an aquarium, a small aquarium, all fish are gone. Try it at home, but be aware that, yeah, you have an empty aquarium later on. It's just, I don't want to ban propofol. I'm using it on a daily basis. But for me, it's important. We have to realize, I mean, on a toxicity scale from 0 to 10, it's got level 9. So it's not a nice milky structure and good to sleep. It is. But it also has its problems, okay? There is some problem with volatile anesthetics, of course, but there is also something with propofol. And this is what we have to do. So, yeah, point 3 are excreted unmetabolized over 60 hours. Yeah, it's not known about the toxicity of their metabolites. Yeah, what is going on with them? Yeah, so it is not black and white, the world. It's colorful. So also be aware of the effect. What are you doing with the waste and with the rest of your propofol? And actually, it should be burned. To be honest, I don't know what the rest of the propofol in my department is going to. I'm not sure that everyone is put into the waste boxes to be burned. Yeah? Okay? Well, what can we do to minimize environmental impact? Yeah, avoid nitrous oxide. You're not you're using nitrous oxide here in Indonesia. That's good. Yeah, that's what we do too. Yeah, okay. So use inhaled anesthetic agents that are not causing a damage of the ozone layer, which is Desflurane or Sevo, but reduce the fresh gas flow. The lower flow you are running, the better you are. So to summarize, in my department, we are using Desflurane as a standard gas in all of our patients, even smokers, asthmatic patients, and COPD patients. We cannot use it for volatile induction because it's pungent. So when we have babies, we have to do a volatile induction. We are using Sevo, and once the airway is set, we are changing back to Desflurane because of the less agitation postoperatively. And this is how we do it. We are using the rule of 24 in the wash-in phase. It takes around 2 to 2.5 minutes to have an onset, to end-tidal concentration of above 5. And then we are reducing the flow to 200 only. And with this, I would like to thank you for your kind attention.
Thank you very much, Professor Pulinga. My name is Cindy. I would act as your case moderator for today. Shall we continue to question and answers, or we go to the case report? It's up to you. Shall we take 3 questions from the audiences, and then we go into case report? So we'll have someone present their cases using Desflurane, and then we can have some comments on that. Okay. Okay, perfect. Super. Okay, thank you. Mungkin ada yang mau bertanya? Okay. Satu lagi. I give you one more. Satu lagi, siapa lagi? Mungkin dari ini. Oke, Boy aja dulu. Silakan, Dr. Boy.
Thank you, Professor. Thank you, Doctor. Hi, Prof. I would like.
Sit down. Okay.
Yeah. I would like to ask about. Is there any contraindication of using Desflurane, and is there any disadvantage comparing the same anesthetic workstation and the same patient profile? Is there any disadvantage of comparing Desflurane with sevoflurane? Thank you, sir.
In my department, we are always using this because it has the big advantage of fast recovery, and quality recovery. Of course, there are some operations where we do not use. There are some operations where we cannot use Desflurane. This is like when we do neuromonitoring for spine surgery. because all gases are decreasing the response. Yeah? But in all the other cases, we are using it. The most important thing is I can induce in everyone in here severe bronchospasm and airway irritation if I wash in too fast, if I drive too fast. Yeah? Exceed, if I go 5 liters on the fresh gas flow and 12% on the vapors, 5.12 times 12 is 60, everyone will get airway irritation. Yeah? So the thing is, we are doing a lot of pediatric cases like ENT tonsillectomies. We are doing all these cases in LMA, no intubation anymore. Yeah? Just LMA, yeah? And Desflurane. So there is no disadvantages. It's only that you wash in softly. And even though with the decent wash in, yeah, you are still faster than with any other technique and you do not cause trouble. So there is no disadvantages. There is only some clear contraindications when you cannot use it because of surgical reasons. Yeah? But we are doing one lung ventilation with Desflurane. We are doing all the robotic surgery, all the obese, of course, the elderly. A big advantage in the elderly, there is no vasodilation with Desflurane because it's a sympathomimetic drug. There is no vasodilation, whereas there is a vasodilation with SIBO and with all the others. When we look at cardioprotection or preconditioning, a big advantage over Tiva. Yeah? But this is also a group effect. This is the same effect for all volatile anesthetics. Yeah? So cardiovascular stability, a big advantage, especially in the elderly and in the obese patients, and of course the wake-up criteria. Yeah? So contraindications, kind of volatile induction in pediatrics, yeah? Neuro, and increased intracranial pressure. If you have a patient with an increased intracranial pressure, Tiva. Because we all know that volatile anesthetics may increase the intracranial pressure, so we cannot use it then. But all the other cases in my department are done with Desflurane. Yeah.
Okay. Yeah, one more. Yeah, kenapa? Enggak.
Well, the washout is very easy. Okay, you can keep the flow and the Desflurane vapor until the very end. You just close down. You increase the flow to 10 liters, and will take around 4 minutes. That's it. Yeah. Okay.
Okay, the other one. Kerasin aja ngomongnya.
Thank you so much for the opportunity, Professor and Doctor. My name is Waluyo from the Anesthesia Register. I would to ask you, if we have a minimum alveolic concentrations indicator in our machine, what is the safest MAC if we use a Desflurane for the surgery?
As I said, it should be around 5 to 5.5 end-tidal concentration. So the machine will always show you the clear mark, because the machine doesn't know if you added fentanyl or something like that. So on the machine it should show you 0.8 or 0.9 mark. So between 0.8 or between 0.8 to 1. Yeah? That means that you are around 5 to 6% end-tidal concentration, because the machine does not know that you added fentanyl. It always gives you the clear mark, yeah, the clear mark, which is 6%. And if you are on 5% end-tidally, the machine will tell you it's 0.8 mark. Yeah. So if it's 0.8 and or between 0.8 and 1.0 mark, that's fine. This is what you should go for. Yeah. 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 Well, we all know that volatile anesthetics can increase, or they do not have a decreasing effect on brain swelling. Yeah. And this is why in a patient having an increased intracranial pressure, you should not use volatile anesthesia. You have to use propofol, yeah, or Tiva. I mean, in the intensive care, if we have an increased intracranial pressure, what are we doing? We are giving thiopentone and we are giving mannitol to get fluid out, yeah, and that's the point.
One more question. So it's always been for
I just talked
Desflurane.
about it. I mean, there is no effect. Professor Slingo clearly said there is no climate impact because there is not enough molecules.
Okay.
I mean, the anesthesiological publications from anesthetists pretending to have climate knowledge, they always said, well, you know, the lifetime is longer than with SIBO. That's right. Yeah. But Professor Slingo says the amount, because it's such a low amount of I mean, it's like only 960 tons comparing to millions of tons and billions of tons of CO2. Yeah. She says it's lost in this noise and the complexity of the climate system.
Yeah.
She just recently asked me when I said, you know, but there is a lot of anesthesiological publications from anesthetists.
Yes.
She said, Professor Pöringer, would you like to be anesthetized by a climate researcher or by an anesthetist? And she said, please,
Makes sense.
let me talk about climate and you do your job as an anesthetist.
Yes,
okay?
makes sense. Okay.
Because there is some anesthetists pretending to have climate knowledge.
I see.
And what they publish is just bullshit. Because Professor Kleinberg just recently made that publication and Professor Slingo. And I was talking to Professor Kleinberg from Boston half a year ago at an advisory board. And I said, hey, Prof, why didn't you publish this already 2 or 3 years ago? And he said, Professor Pöringer, just a relation. When you come up with a cup like this, full with sand, and we are standing on a beach with 100 kilometers long, and you say, well, what is the impact of this tiny little cup of sand here? You would say, in the presence of a 100-kilometer long beach, I'm laughing at you. And this is what we were laughing at anesthetists pretending that Desflurane has an impact on the climate. Because it's like a cup, a small cup, in the presence of a 100-kilometer long beach. It's not enough molecules because there is billions of tons of CO2 with a lifetime of 100 of years. There is millions of tons of methane with a lifetime of 75 years. And now we are talking about the drug with 10 years lifetime and just 1,000 tons. It's lost in the complexity of the system. They say, of course, there is some impact, but the impact, as I showed you, for 100 years, doing only Desflurane all around the world, no other anesthesia technique, and the increase will be 0.002%. 3 degrees, nothing.
One, I get it from the online YouTube. One is asking about the drug interactions between Desflurane and other anesthetic agents. Is there any specific considerations using other
there is
anesthetic
one, no,
agents?
there is no interaction. I mean, what we all have to keep in mind is that all volatile anesthetics are kind of influencing recovery of neuromuscular blocking drugs. We know that there is about 25% longer duration of action of neuromuscular blocking drugs with all volatile anesthetics. So if you're using Tiva and rocuronium, probably you have a recovery within 45 minutes. And if you use any gas, no matter which one, the recovery will be around 10 minutes longer. This is why I told you, and this is why the recommendations are from the American Society and the European Society, every patient receiving a neuromuscular blocking drug should get TOF monitoring because it's very individual. And we cannot predict recovery from neuromuscular blockers. This is why we should measure. In my department, every patient receiving a muscle relaxant gets neuromuscular monitoring.
Okay. Thank you very much. We shall continue to the case presentations to maximize with our time. To Dr. Nugraha, isn't it? He will present some cases on it. Professor, if you may, if you wish to sit down. Yes. Yes. Okay. Langsung slide-nya aja.
Okay, good morning, everyone. Thank you for attending in this guest lecture. First of all, I wanted to introduce myself. My name is Nugraha. I'm anesthesiologist resident here in Prof. Ngurah Hospital. And I would like to say thank you, big thank you to Professor Frederick for will come to Bali and sharing with us about matter about Desflurane. It's something new, I think. Honestly, we do have Desflurane in here, but it's very rarely we use it in here as a inhalation agent to sedation patient in here. We common use sevoflurane rather than desflurane in here, but it's something new. But we do have the desflurane in here, and I want to present a case in one of case in Prof. Ngurah Hospital. We use desflurane as a inhalation again. The patient is a suspect malignant ovarian neoplasma, and let's try to start to the case. The patient is female, 29 years old, and come to the Prof. Ngurah Hospital with the diagnosis is suspect malignant ovarian neoplasma, and the procedure planning with the obstetric, they will do the paratomy, surgical staging until the frozen section to surgical staging. So based on the conclusion, patient physical status ASR, 3 with planning to general anesthesia, and we will do the rapid sequence intubation. Okay, okay, next. Okay, start from the anamnesis. The patient history came to the hospital with chief complaint is abdominal enlargement. It felt since January 2025. It's accompanied with vaginal spotting and foul smelling and vaginal discharge. Patient declined all any complaint like itching or postcoital bleeding. She also have still good appetite, normal urination and bowel movement, and she still has good defecation. The patient declined about much weight loss, fever, shortness of breath. There is no history of drug or allergy. The doctor also declined about systemic illness like hypertension, diabetes mellitus, or asthma. Patient also declined about history of previous surgery, and patient in daily activity able to do some moderate until heavy activity. From the physical examination in the vital sign, the weight is 60 kilogram and the height is 157 centimeter. We found the body mass index is 24.46 kilogram, and from the axillary temperature we found 36.7 Celsius, and for the numerical rating scale at the rest is 1 and at the movement is 2. From the FPL score we found it's 3 and the MET score is 5 until 6. From the systemic review from the central nervous system is the patient still compos mentis, and from the respiratory there is no problem. The respiratory rate is still 16 beat per minute. The saturation oxygen still good, 99%, and the clear breath sound is still vesicular. There is no because the diagnosis is suspect malignant of the ovarian. We suspect it's FUC on the pleura, but we found it's still clear, still vesicular. And for the cardiovascular, we found the blood pressure is 120 per 73 millimeter mercury, and from the heart rate is 96 beat per minute, and still normal heartbeat sound good. From the abdominal, right now we found is the distended from the abdomen, and we found some cystic mass. Approximately the size is 30 by 30 centimeters. It's well-defined border, smooth surface, and limited mobility. From the original, the patient is still able to do spontaneous urination. Okay, this is the clinical present of the patient. As you can see, the distended of the patient is like the patient having a pregnancy as maybe 36 week. It's very distended, but there is no complaint about shortness of breath. The patient was also can sleep with one bag. Okay. Okay, from the supporting examination result, as you can see from the laboratory test, complete blood cell is still normal. Hemostasis level is still normal. From the biochemistry is still normal. As you from the imaging studies, from the X-ray thorax, we found some abnormal like minimal bilateral pleural effusion. And from the abdominal ultrasound, we found loculated hypoechoic, hyperechoic mass with septation, papillary projection and solid part, and posterior enhancement. Okay, this is the X-ray thorax. It's visible the effusive pleura bilateral. Okay, this is the current and potential problem. The first one is from the current problem. From the respiratory, we know the patient have minimal bilateral pleural effusion from the chest X-ray, and but no from the lungs is still good, vesicular, no complaint about shortness of breath. From the gastrointestinal tract, we found distended. It's suspect malignant ovarianoplasma with mass is approximately the size is 30 by 30 centimeter. From potential problem, the first one is aspiration, of course. The second one is bleeding. The third one is post-operative nausea and vomiting or PONV. And the last one is re-expansion pulmonary edema when we start to take out all the mass inside the abdominal. Next. Okay, from pre-operation and anesthesia plan. Of course, the patient is normally we start the fasting 8 hours before the surgery or before the inhalation drug is given. But we give the patient explanation fasting more longer for 12 hours, and for the anesthesia plan we planning to do the rapid sequence intubation. Okay, the first one is arterial line, and then the primary medication we give metoclopramide 10 milligram IV line and ranitidine 50 milligrams by IV line. And patient the head is positioned head up 30 degrees. The first, if we give pre-oxygenation 100% oxygen in the first 5 minutes. From the analgesic, in the last 3 minutes we give the fentanyl 100 microgram, and from the last 1 minute induction we give rocuronium 60 milligram and propofol 120 milligrams with Select maneuver. And the time is up, it's already 0, and we do the intubation with endotracheal tube, which size is 7.5 and cuff at level 21 centimeter. Yeah, okay, and the maintenance we give the oxygen and compressed air and Desflurane. Approximately the volume of Desflurane is 3 until 6% from and for fentanyl we give the 25 until 50 microgram every 45 until 60 minutes. It's intermittent. And for the rocuronium, we give 0.1 milligrams per kilogram every 45 until 60 minutes intermittent. For other medication, we give ondansetron and asam tranexamate and tranexamate acid. Okay, next. I think better. Okay. For the post-operative care and conclusion, post-operative analgesia, we give patient morphine 20 milligrams plus ketamine 20 milligrams in normal saline 20 milli, and by serum pump we start it 0.8 milliliter per hour. And for the NSID, we give paracetamol 1000 milligram every 8 hours and ibuprofen 400 milligram every 8 hours. And after the surgery, patient disposition to the intermediate care unit for continued monitoring and recovery. From overall conclusion, the patient underwent successful surgical staging for suspect malignant ovarian neoplasma and post-operative diagnosis pending histology result. Okay, first of all, understanding gynecologic laparotomy. What is gynecologic laparotomy? Gynecologic laparotomy is the major surgical procedure for various conditions in the female reproductive system, including suspect malignant ovarian neoplasma. It's required general anesthesia for safety, hemodynamic stability, and efficient post-operative recovery. And ovarian neoplasma is most common disease in reproductive woman age. It's suspect malignancy present diagnosis and management challenge. Laparotomy also serves both of therapeutic and diagnosis for the staging or debulking when feasible. Why the important the hemodynamic stability? Hemodynamic stability is crucial in major surgery. It's also it's also crucial in major surgeries like gynecology laparotomy, which its large incision, organ manipulation also is potential. It's potential to leading to massive bleeding and vascular change. So selective anesthetic again is important to prevent the complication like bleeding, to maintain the blood pressure and heart rate in visual. Okay, why Desflurane as key advance? So Desflurane, as we know from the Prof. Frederick already told us about the advanced use, the rapid onset and recovery. So Desflurane over quick onset and offset. Do its low blood gas partition coefficient, it's approximately 0.42, and leading shorter extubation times, it's to 20% reduction in sevoflurane and 34% in isoflurane. It's also have cost effectiveness, so it should be cost effective, but in this case we use Fabius Drager ventilation machine. So I don't know. In this case, it's not cost effective than the sevoflurane, to be honest. And in myocardial protection, desflurane provides protective effect on the heart. It's making it suitable for patient undergoing cardiac surgery. For the pharmacokinetic and elimination, desflurane low blood gas partition coefficient mean it does not accumulate in the blood. It's facilitating rapid recovery after prolonged general anesthesia. It's also rapid elimination allow end-tidal concentration to reflect arterial blood concentration during well-assisted ventilation and aiding recovery prediction. From the cardiovascular effect and stability, Desflurane has minimal cardiovascular depressant effect than other inhalation again than sevoflurane or isoflurane. Yeah, of course, and propofol, Tifa, of course. While head concentration or rapid increase can cause sympathetic stimulation. So, nevertheless, while head concentration of desflurane, uh, it can be sympathetic stimulation. So it have to careful the titration maintains the volume of the desflurane because it can be increase the sympathetic stimulation. So it's the heart rate during the surgery will be high. Okay, and study show desflurane with low flow technique and multimodal analgesia is provide hemodynamic stability comparable to or better than sevoflurane or propofol to maintain the vital organ perfusion. Okay, so the mechanism of action desflurane. Desflurane is a halogenated ether. It disrupt the central nervous system signal transmission through the potential. The first one is potential of GABA A. It enhances the GABA inhibitory action by increasing the chloride influx and inhibiting impulse transmission. The second one is the effect on two pore domain potassium channel. It activate the potassium channel and leading to membrane hyperpolarization and reduce the neural excitability. And the third one, the last one, is inhibition of NMDA receptor to suppress the excitatory activity via the glutamate pathway. But TRK is not the primary mechanism. Okay, the indication for desflurane use. The first one is major surgery procedure. The surgery is moderate until long duration is good. Like the example, the laparotomy or the others. And then the second one is ponfil risk or post-nasal vomiting risk and neurological evaluation. So desflurane has the rapid onset and offset. So it's good to neurological assessment those needing early. So and the third one is hepatic and renal impairment. It saves the patient with limited hepatic or renal function due to the minimal hepatic metabolism. And for the obese patient, it's good because the rapid metabolism and pulmonary elimination allow faster recovery and reduce the residual anesthetic exposure. Okay, for the contraindication and conclusion, for the contraindication, there is two contraindication. The first one, absolute and relative contraindication. The absolute contraindication, the first one is MH or malignant hyperthermia. So desflurane is triggering again for this life-threatening genetic condition. So like the older inhalation again, it also have triggering the malignant hyperthermia. The second one is hypersensitivity. So the patient with hypersensitivity to the other isoflurane is risk to have hypersensitivity to desflurane also. So the relative contraindication is active airway disease such as asthma or acute bronchitis due to airway irritation risk. The second one is increase in cranial pressure. The third one is severe ischemic heart disease because the sympathetic stimulation. So it must be the fall is titrating. Choosing desflurane for anesthesia. So in this patient, especially this patient, desflurane was selected as primary inhalation anesthetic with female 29 years old with SA3 status undergoing gynecologic laparotomy. The choice was driven by several key pharmacology advance and it's crucial for the patient with moderate systemic condition. From the pharmacological advance, the first one is rapid onset. Pulmonary elimination is fast, and precise anesthetic control is higher. The potential risk and management, despite its advance of Desflurane, there are risk and management in using the Desflurane. The first one is airway irritation. The second one is it has to monitoring close because the potential of the stimulation of the sympathetic nerve. It's also sorry. Okay, it's also potential require of hypotension. So requiring of fluid transfusion or vasopressor support, it may lead it's required in the several patients. Okay, use Desflurane in gynecologic laparotomy. There is no significant impact, to be honest, because Desflurane and sevoflurane, we very rare to use in this hospital, but the impact that I felt when use Desflurane is the onset is very fast than other inhalation agent. But from the hemodynamic during the operation, there is no significant difference with sevoflurane. No substantial immunosuppressive effect. And for the post-operative recovery and adjuvant therapy, Desflurane rapid post-operative recovery is significantly benefit, enabling quicker neurological and physiological monitoring, and following major surgery and facilitating earlier initiation of adjuvant therapy if required. Addressing challenges and ensuring safety despite the challenge in airway irritation and sympathetic stimulation, the strategy of Desflurane with multimodal anesthetic approach coupled with close intraoperative monitoring can effectively prevent complication and significantly improve the patient's safety. The first one is multimodal approach, the close monitoring and prevent the complication. Next. Okay. The last one from me, the key takes away and next step. This one is over significant advance for high risk surgical patient due to its rapid action and minimal systemic impact, and we should be continuous research and clinical application to it will further refine its use. Thank you for your attention. That's all from me. I'm going back to the Dr. Sindri.
Thank you so much.
Okay, for the maintenance intraoperative, we use Desflurane. We use 3% foam, anti-threatening based the condition of the patient until 4. There is no above 4, only below between 3 until 4%, Prof. Yes.
Super, thank you. Is there any specific agents while you were giving those high doses opiates? Because somehow I think they're trying to do that due to the risk of the hemodynamic disturbances. While we are
But you know, to be afraid is one thing. But we are time of evidence-based medicine. And fentanyl and opioids do not have any cardiac depression. We call it a cardiac. There is no depression at all. Depression is caused by propofol. So So this is so important. In the elderly, I'm giving 200 mg of fentanyl, but I'm just giving 60 or 70 of propofol because this makes the cardiac depression and this makes the hypotension, but not the fentanyl. That's important. So don't be afraid of fentanyl. Be afraid. Again, this makes the depression. This is what we have to keep in mind. And again, I do not pretend that my techniques are the only one. But this is our philosophy. We are trying to fill up the patient with opioids to have a good analgesic level and to have a stable cardiac situation. Desflurane has had no vasodilating effect. This is a non-opioid drug, so it has no vasodilation, even in higher concentration. So the thing is, one thing is that not upon anesthetic level.
Thank you. Do we have any additional questions, new questions from the online, or shall I use the questions that you have sent me? No new questions. Okay. Professor, there are some questions from the online viewers. They are asking about the Desflurane used for for respiratory compromised patients, such as maybe abscess or pleural effects, or maybe ARDS, or maybe patients with pulmonary complications. Whether you're still using it or you change into other agents for thoracic procedure, like still using Desflurane.
There's no, I mean, if I had a patient with an asthmatic attack,
Yeah. How about asthmatic attack? Yeah.
I mean, a patient with an acute asthmatic attack is usually not in the OR. This is in the emergency department. Okay? And of course, this would be a patient where
and just want to do surgery.
This is a,
Yeah,
this is
yeah,
an internal
yeah,
medical
yeah,
problem,
yeah.
and this is not. But
Yeah.
for this patient, if you had that situation, SIBO would be of advantage.
Yeah.
But we do not have it. When we do thoracic surgery, we are still using one lung ventilation. We are using Desflurane because we want to extubate these patients fast. We want to have their airway reflexes fast back. We want.
Okay.
So that's the advantage.
Thank you. It's very thorough explanations. Do we have? Le- so late or so delayed. Why would that?
The thing is, you know, there is one Nobel one who has a citation index of 690.
Yeah,
This is William Sachs vaccination portfolio.
yeah,
Okay? And if we look at my vaccination index, which is around, I don't know, 15,000, I'm not important. Because it's not that the amount of
the citations. Yeah,
if you have one publication which changes the world,
yeah,
this is important. So the argument that some of the papers I show are from
yeah,
19
yeah.
years,
Yeah,
I mean, I would like to show you the value of those findings.
Okay.
And I mean, can you show me one paper from SIBO where SIBO is superior to Desflurane? Please show me. I cannot find them because you can tell me they were publishing. It's cardioprotective. It's liver protective.
Yeah.
It's blah blah. But this is already findings that have been done in 1969 for halothane. This is a group effect.
okay.
The only benefit that SIBO has over Desflurane is that you can make a volatile induction. If you tell me that you give me as a patient a SIBO anesthesia, I would say, very sorry, madam, you are not my anesthetist.
Okay.
Because I would like to have SIBO as a patient. Because I want Desflurane. I want to recover fast. I would like to have my airway protection, and I would like to have hemodynamic stability. So as a patient, I want propofol for induction. I want fentanyl. I want rocuronium, probably sudamadex to reverse my residual paralysis.
Yeah.
And I want Desflurane.
Okay.
I want a little bit of dexamethasone, 4 milligrams. I want 4 milligrams of ondansetron
Yeah.
to prevent post-operative nausea and vomiting. This is what every patient in my department gets. 4 milligram of dexa and 4 ondansetron.
Ondansetron. Yeah.
This is our
Yes, like
prophylaxis.
yeah.
And nothing else.
Okay.
And if you do not provide this for me,
Okay.
you're out of the race. Yeah.
I
And
see.
again, it's not important when data are produced. It's important what they say. And if there is any research telling that this is not correct. But of course, I mean, Desflurane was in America introduced into the market and in Europe in 1995. So after those years, the
Yeah.
research started. And it's established. I mean, I implemented Desflurane in my institution 25 years ago.
Yeah.
So the thing is, things are going on, and if it's working well, why should you change it? Yeah. And
Yeah.
those data that were coming up, you know, like is not influenced. Yeah. And we have good results on that. These data are evident, and they have a value, and there is no timeline on it that after 10 years the values are not realistic anymore.
Yeah.
It's just if you show data from Bali that what I said is
Yeah.
wrong, please publish it. But
Okay.
you will not be able to gather that data because it works.
And And how about the cost effectiveness? I know that you have played this in your hospital with your hospital administrator, that you have compared between sevoflurane and desflurane. But how in a higher level, in a very large data, in a very large patient subject and groups? Because it's still in single center again, so it's like maybe just in I think it's a little bit ironic because the United States used to pronounce or announce the use of Desflurane, but later on that years they already stopped using or maybe making research on it, but more from the European countries using Desflurane, while the United States are more into the propofol for inductions or maybe like something like that. How about the cost effectiveness on maybe several hospitals? Have you ever known about the recent publications? What I've searched through is just maybe just one single center from the New York Beth Israeli, and they found that because due to the cost effectiveness study, they rather choose the sevoflurane rather than desflurane due to the data regarding the retrospective analysis on their patients using of the volatile anesthetics. Well, how about your comments on that?
Well, it's all about the flow. That's what I showed you.
I
you
see.
know, and if
Okay.
you look at this study from Beth Israel Hospital,
Yeah.
they were having higher flows on desflurane.
Yes.
So when I see this kind of studies, I'm just laughing at it, because if I leave the shower running on, and turn around and I say, well, you know, it costs more.
Yeah.
I mean, what I clearly showed you, the lower the flow is, the less money it is.
I
So
see.
you can prove it for your hospital, if you're interested in. If you're not, well,
Okay.
I mean, that's the thing.
Yeah.
It's always that we can always have this discussion. Oh, you know, these are old data, and this is just single center and blah, blah, blah.
Yeah.
But these are the facts. The lower the flow you have, the less money you spend. We were doing a Draeger monitoring and
Yeah.
Draeger machine. They show you that you can press
Yeah.
the consumption.
Yeah.
You see the flow. So just recently in Hanoi and in Manila,
Yeah.
we were having Draeger machines. I was doing low metabolic flow anesthesia, 1.5 hours, and at the end the machine said 7 milliliters of Desflurane. So it's only a single center result. But you know, if I calculate that 240 milliliters is like 120 euros, I can easily calculate how much money this was. And I can run the next anesthesia with 2 liters fresh gas flow, and the machine tells me 50 milliliters, and then I can compare whether my technique with the metabolic flow is cost effective or the other one with the old technique. Yeah, that's very easy. So the discussion, it's a single center. It's just,
Yeah.
you want to spend for the same thing 5 times more money, you can do it. Just go to a Shikimiki shopping mall and you pay for a durian 20 euros, or you buy it on the street and get it for 2 euros. Well, it's single center, but that is the difference, and this is what we have to realize, that if we reduce the flow, we reduce the cost. And if I publish that I'm doing a 1 liter fresh gas flow anesthesia with Desflurane, the cost is 5 times higher than mine. It's very clear, and therefore I'm not a fan of this kind of comparison,
Yeah.
because it's always about your institution. And
Yeah.
if you say we are using higher flows, well, I don't mind. They will love you. But
Yeah.
in my institution, we are reducing because we want to save the money. We don't want to save the money to the US.
Yeah.
We want to keep it in our institution.
Have you managed this technique on other machine as well, not
Of
only
course,
Draeger?
on all
On
machines,
GE,
machines.
Draeger,
Yeah.
what else?
Mindray.
Mindray,
Yeah.
what else?
Yeah, yeah.
What do you have?
And
Covidian. Yeah. Yeah.
It's all the same. And the next thing is, I mean, if you are talking about costs,
Yeah. Cost.
it's not only the drug cost. I mean, what about the cost of a minute in the operation room? I mean, the 1 minute in the operation room in Germany costs around 12 euros. Okay? If we save those
okay.
times, we save money in terms of process time. This is important. And Dexter and all from the US, they did a meta-analysis containing 32,000 patients. And they found that there was a 75% reduction in prolonged extubation times. And if you save like 5 or 10 minutes on 5 cases a day, you can do an additional case, which brings money to the hospital. Yeah. And this is the thing, that the same people, the same amount of people can do 1 case more without extra labor cost. This is cost effectiveness. So it's not only the price of the anesthesia, it's also the price of the process cost. And there is no discussion that this is a big advantage for Desflurane. No matter single center, multi-center, or
Yeah, I
whenever
see.
public.
I see. Thank you so much. Do we have any other comments from the floor, from this side? I didn't hear anything from you. Can you speak up, please, William atau siapa yang lain? Wigun, Adinda, Michael, you have any questions from the Dr. Muda? Maybe questions on other volatile anesthetics? Ada lagi? How about concerns on pediatric patients, doc? Professor, do you want to reduce the dosage or just the regular one? Or you want to combine with something others?
No, I don't combine.
You don't combine, okay.
Again, combinations are always bad. Okay? Because the big advantage of Desflurane is the low solubility. If you have that advantage, you should not combine it with anything. Because the fast wake up is the big advantage. And this is the reliability and the predictability of the drug. So in pediatrics, we are not reducing the dose, because in pediatrics the drug is higher. We have 6% impact. That's what I said already in my presentation. Yeah. Okay. So what we are doing in pediatric cases, we try to line it before we put the PEMPA cream already. Yeah. We try to always do an IV induction. Very rarely we do a volatile induction. Airway is set, we go back to Desflurane. Yeah. Because postoperative agitation in pediatrics is less. Yeah. So we try to do an IV induction.
Thank you very much. Very clear presentations and also very nice and quick answers, questions and answers. If we don't have any more questions, so this should be a wrap. Thank you very much, Professor Puringer, for a very nice and, as we say in German, pünktlich presentation. Is very nice done. And thank you very much for the opportunities from the Kalbe and Baxter to help us with this guest lecture. I really wish you a very good day and also have a more thorough understanding on Desflurane. And we really hope to see you if we could use Desflurane in other side in operating theater. Thank you very much. I will give this as the MC. You may close this thing up.